Historically, preoperative care relied on subjective clinical intuition. Physicians performed basic evaluations to clear patients for surgery, treating the operative date as a static checkpoint. This passive approach left the massive physiological burden of surgical stress entirely unchecked. The 2024 American College of Cardiology and 2022 European Society of Cardiology guidelines explicitly abandon the concept of routine clearance. They mandate a transition to active, biomarker-driven physiological optimization. This intensive protocol applies specifically to elevated risk populations undergoing major non-cardiac surgery. That includes major vascular interventions, abdominal oncology resections, major orthopedics, and thoracic procedures. This new clinical standard is an 8-domain pathway targeting modifiable risk factors along a strict temporal timeline, starting 6 weeks before surgery. When executed correctly, this multimodal approach reduces 30-day mortality, major adverse cardiovascular events, and myocardial injury by 25 to 50%. Achieving these survival metrics requires replacing subjective judgment with rigid, quantified protocols tied to specific preoperative deadlines. The pathway must activate exactly 6 weeks before surgery. This specific lead time is required to transition away from untargeted routine lab panels and begin mandatory objective risk stratification. This matrix displays the revised cardiac risk index using 6 predictors. Its predictive power, peaking at a 0.77 C statistic, is imperfect. Adding NT-proBNP testing improves accuracy, shifting the C statistic to 0.73 and reclassifying risk for 26% of patients. Functional capacity assessment undergoes a similar quantitative correction. The 2018 METS trial proved that a clinician's subjective estimation of a patient's physical fitness has only a 19.2% sensitivity for detecting true functional impairment. The guidelines now dictate using the Duke Activity Status Index, or DASI. This 12-item questionnaire objectively calculates peak oxygen uptake. A DASI score below 34 identifies the precise threshold where postoperative mortality and cardiovascular risk sharply accelerate. For thoracic patients facing lung resection, the pulmonary alveolar is at absolute. Candidates require forced expiratory volume and diffusing capacity values above 80% predicted. Anything lower triggers mandatory predicted postoperative calculations to determine strict surgical operability. Objective measurement extends to frailty and nutrition. Data from 50,000 surgical patients establishes a serum albumin level of 3.4 grams per deciliter as the strongest preoperative predictor of 30-day morbidity and mortality. Clinical estimation consistently fails to identify vulnerable patients. Objective scoring algorithms and specific biomarker thresholds are the only reliable mechanisms for isolating elevated risk cohorts. Even mild preoperative anemia acts as an independent multiplier for 30-day mortality. Current consensus mandates evaluation and intervention for any patient presenting with a hemoglobin level below 13 grams per deciliter, regardless of sex. The timing of this intervention dictates its success. The PREVENT-TET trial attempted to treat anemia with single-dose IV iron, but showed no outcome benefit. The trial failed because the medication was administered a median of only 15 days before surgery. It takes 4 to 6 weeks after intravenous iron repletion to achieve a functional rise in hemoglobin. This chart highlights the importance of specific drug selection using data from the PHOSPHARE trial. Ferric carboxymaltose carries a severe 74.4% risk of inducing hypophosphatemia, compared to only an 8% risk when utilizing ferric derisomaltose. The 4 to 6 week window is also when baseline cardiovascular markers must be established. High-sensitivity troponin serves a dual purpose. It prognosticates existing chronic myocardial injury, and it anchors the reference point for detecting fresh ischemic damage after surgery. The 2022 European guidelines elevate this to a Class 1 mandate. Any patient over the age of 65, or possessing cardiovascular risk factors and undergoing intermediate or high-risk surgery, must have a baseline high-sensitivity troponin drawn. Generating red blood cells and identifying chronic cardiac stress are biological processes that cannot be accelerated. The absolute limits of human physiology dictate this mandatory preoperative timeline. The role of perioperative statins was heavily contested following the retraction of the DECREASE-3 trial due to scientific misconduct, but robust independent validation has since clarified the absolute necessity of statin management. This forest plot separates the discredited decrease data from massive independent cohorts like VISION and VASQUIP. These validated studies confirm that statin therapy yields a 43 to 54% reduction in perioperative myocardial infarctions, driving a significant drop in 30-day mortality. Statins achieve this through pleiotropic effects. Within 24 to 72 hours, they induce endothelial stabilization and reduce inflammation, protecting the vascular wall during surgical stress. Because of these stabilizing properties, chronic statin therapy must never be interrupted. Stopping statins perioperatively triggers an inflammatory rebound and dangerous troponin release. The evidence is so definitive that the 2024 ACC/AHA guidelines upgraded the de novo initiation of high-intensity statins to a Class 1 recommendation for statin-naive patients with cardiovascular indications. Initiating long-term statin therapy in the preoperative clinic establishes a primary intervention point for lifetime cardiovascular disease modification. Managing metabolic control requires precise pharmacologic timing. For elective procedures, the clinical target is an HbA1c below 8.5%. However, the American Diabetes Association explicitly dictates that surgery should not be delayed solely on this metric without multidisciplinary analysis. The landmark NICE sugar trial demonstrated that attempting tight, intensive glucose control intraoperatively actually increases 90-day mortality. The current consensus targets a moderate range of 140 to 180 milligrams per deciliter. The real metabolic danger lies in SGLT2 inhibitors. Under surgical stress, they force the body's metabolic pathways into aggressive ketogenesis, despite normal blood glucose levels. To prevent euglycemic ketoacidosis, mandate stopping SGLT2 inhibitors 3 to 4 days preoperatively. For GLP-1 agonists, 2024 guidelines recommend shared decision-making based on gastric emptying risks. Finally, aspirin for primary prevention increases major bleeding, requiring a hard stop at day -7. Conversely, patients on dual antiplatelet therapy for secondary prevention face strict minimum continuations, 1 month for bare metal stents and 3 to 6 months for drug-eluting stents before elective surgery can safely proceed. The success of the operation relies entirely on executing this precise pharmacologic de-escalation in the final days preceding the procedure. Day 0 is the point of maximum physiological vulnerability. It is also the phase with the highest risk for iatrogenic harm due to the mismanagement of autonomic and antihypertensive medications. This logic tree maps Day 0 hemodynamics. Patients chronically taking beta blockers, alpha-2 agonists like clonidine, or calcium channel blockers must continue their dosages to prevent severe rebound tachycardia and hypertensive crises. The POISE trial demonstrated the catastrophic consequences of altering beta blocker status. Initiating high-dose metoprolol on surgery day increased all-cause mortality and doubled stroke rates. Based directly on these findings, there is a strict Class 3 harm recommendation explicitly prohibiting day-of beta blocker initiation. The 2024 Stop or Not trial resolved the debate over ACE inhibitors. While continuing or holding ACE inhibitors does not affect overall 28-day mortality, continuing them causes significantly higher rates of intraoperative hypotension. The current best practice is to hold them on the morning of surgery. Intraoperatively, the hemodynamic target is absolute. The anesthesiologist must maintain mean arterial pressure within 20% of the patient's baseline, enforcing a strict minimum of 65 millimeters of mercury. Violating this threshold is heavily penalized by human physiology. Data from 33,000 patients proves that dropping below a MAP of 55 for just minutes immediately increases acute kidney injury and myocardial damage. Day 0 is strictly about maintaining established autonomic stability. It is never the time to initiate new pressure controls or attempt aggressive blood pressure normalization. The optimization pathway extends into the post-operative window because over 80% of myocardial injury after non-cardiac surgery presents asymptomatically. Relying solely on clinical observation guarantees these ischemic events will be missed. To capture this silent damage, the European Society of Cardiology established a Class 1 protocol requiring high-sensitivity troponin draws at exactly 24 and 48 hours post-operation for all at-risk cohorts. Post-operative blood management follows similarly strict parameters. The standard of care demands a restrictive transfusion threshold, maintaining hemoglobin below 7.0 to 7.5 grams per deciliter to minimize complications. This master temporal chart maps the entirety of the evidence-based continuum. It replaces the outdated, disorganized model of surgical clearance with an exact chronological blueprint, tracking the patient from week -6 to hour +48. The highest yield clinical directives are clear. Utilize objective DASI scoring, systematically initiate statins, execute precise pre-surgical medication holds, and deploying multimodal surveillance to prevent myocardial injury. Strictly implementing this comprehensive 8-domain pathway transforms the practice of perioperative medicine into a primary, foundational driver of long-term patient survival and health.